Yes, I'd like to present unpublished data from our study, robotic versus laparoscopic bariatric surgery, particularly in the very first 50 cases after introducing the robotic system to our hospital. Therefore, we created a matched pair analysis to check if it's visible and if it's safe. Like I said, particularly for the very first 50 cases. We started collecting data with the first patient in March 23 to September 24, and we did 185 bariatric procedures. We excluded all revisional surgery and all redo operations, and therefore there are 50 robotic cases left and 90 laparoscopic cases. Then we performed propensity score matching by gender, procedure, age, and BMI. In Sylke, we created our study groups, 50 robotic and 50 laparoscopic cases. You may guess the ratio of males and females. I'm sure you are getting the right result. 70% of our patients were female and 30% were male. That's almost the same in other studies where the rate of women is higher than men. Patients' characteristics, average age was 43. That's quite old. In Germany, patients always come very late for bariatric surgery. The average BMI was 48, average weight 147, and surprisingly, in the robotic group, we find more previous surgery in history. Actually, we suspected a lower rate of surgery in the history. That was actually significant. For evaluation of the patient condition, we used admin and obesity staging system, which is based on the assessment of mental, medical, and functional quality of patients' health. There are 5 stages. And we only classified patients for the group 1, 2, and 3. The stages are from the very healthy patients to very sick patients. And for this, we found out that patients in the robotic group were in a better condition, and that's for sure due to patient selection for our study. Surgical technique, we always use nasogastrial tubes, 36 Charriers. Position was for the laparoscopic group in a beach chair position. We used 4 ports, 1 for camera, 1 for the liver retractor, and the 2 left ports for instruments. In the robotic group, again, nasogastrial tube. The position was always 20 degrees anti-Trendelenburg, and we used 6 ports. 4 Da Vinci ports, 1 assistant port to insert the cartridge device, and 1 for the liver retractor. The surgical technique inside the abdomen was almost very equal in both groups. For resection of in sleeve gastrectomy and for the building of the anastomosis, we used cartridge stapler devices by Medtronic, and the insertion place was closed by a simple suture. We did fluorescence imaging for perfusion control in all cases, especially because of the very first cases to feel safer. We normally don't do that in bariatric surgery, only for revisional surgeries and redo procedures. And unfortunately, the Da Vinci robotic system doesn't supply an overlap mode. We always had this green color and the black background, but we strictly use it for all patients in our study groups. If you are looking for data concerning robotic bariatric surgery and fluorescence-guided techniques, you will find nothing. I find only one study with 150 patients for the leak test. They have given the ICG over the gastric tube to check the staple line and detected 2.6% of leaks. So I know it's often discussed to if it makes sense to use ICG for leak tests rather than methylene blue. We actually always use methylene blue for that. And pictures. Back to our results concerning the duration of surgical procedures. The robotic procedures significant took much longer than laparoscopic procedures, almost around about 15 minutes. To figure out the reason for that and where we lost all the time, we splitted the time in the pure operation time inside the abdomen and the time for setup, and therefore clearly we could show that all the time left for the setup and the robotics procedures to connect the trocars with the robotic system, and that took much time. Fortunately, the learning curves for robotic sleeve gastrectomy and robotic gastric bypass show an improvement over the time. That makes me happy. Morbidity, we didn't detect any intraoperative complications in both groups. The blood loss was minimal. Post-operative morbidity, Clavien Dindo 1 and 2 was equal in both groups, robotic and laparoscopic, and fortunately we had a mortality rate of 0, even for the entire study group of 185 persons. Clavien Dindo 3, the reoperation rate, we had 1 in each group. One in the robotic gastric bypass group, 10 days after surgery, patient needed readmission and a relaparoscopy. We found leakage in the GJ junction. And the other case was after a laparoscopic sleeve gastrectomy, 1 day after surgery with the bleeding from the suture line. Both patients were handled by laparoscopic procedure and with a suture. Postoperative outcome, there were no differences between both groups. Duration of hospital stay compared to United States, I guess it's longer. Our patients stay 4 to 5 days. Readmission rate 4%, and the weight loss after 3 and 6 months follow-up was almost the same, 26 and 33 kilograms. Blood test results, we checked the levels of VBC and CRP preoperative, and after the operation there were no significant differences, but we found surprisingly a trend. We found a lower CRP level at the first day after robotic procedures, which doesn't make really a sense because we had a longer duration of surgery and had more trocars. I cannot explain that, but I want to show it. If you check the literature, you will find a lot of studies dealing with robotic bariatric surgery, also with huge numbers of patients. But if you notice this, the next numbers, these are the rates of robotically done procedures. You will find 6.6%, 13%, 11%. That's really low. And in Germany, only 5.7% of all gastric bypasses are performed robotically, and only 1.6% of the sleeve gastrectomies. So it's no standard procedure. And if we go to the results, a lot of studies have shown a higher morbidity rate in robotic procedures, longer operation time, like we did, and a higher reoperation rate. So it's difficult to interpret. For us, we could conclude that the robotic procedures were feasible. For us, they were safe, maybe because of the use of the perfusion control, but it's no standard procedure, and they are not superior to laparoscopic surgery. It's a little bit mixed. I already said that. I go further. And the last point is, I always enjoyed doing laparoscopic procedures, being with the people at the table, having nice talks, and now you're sitting in the corner without any conversation. And I like robotic surgery, but I also like laparoscopic operations. Thank you.